For today, I think what we're going to do is go ahead and wrap up and move into our next panel. If folks do have questions for our panelists, you can still send them in, and we can try to either send those out or find some way to sort of connect the dots and make those connections later. But I do want to keep us on time, and I also want to be respectful for those of our speakers who may have hard stops in terms of where they need to be in the next hour. So I appreciate you all so much for bringing us these messages today, and I look forward to learning more with and from you in the future. I'm going to pass off the baton to Claire Brindis to lead us into the next session. Thank you all.
And thank you so much for that fantastic panel. And in fact, you all have laid the groundwork for the session that we're moving into now, which is session 7, the implementation of statewide policies and mandates to advance maternal health equity. It is a tremendous pleasure for me to introduce to you our next set of speakers who will go into deeper examples of the kind of work that Ms. Henderson was just sharing with us, because state action is really one of the most important partnerships that we can advance in this arena, and to really seek new mandates that advance the maternal health equity lens that we have been talking about for the last day and a half. Our first speaker is Dr. Ann Borders, who is the Executive Director and Obstetric Lead at Illinois Perinatal Quality Collaborative, as well as a maternal fetal medicine physician with North Shore University Health System. She's also a clinical associate professor of obstetrics and gynecology at the University of Chicago. And Ann, it's really a pleasure to hear from you as to the kind of work that you've been doing. Thank you.
Absolutely. Thank you so much. I am so pleased to get to be a part of this amazing workshop. Listening in yesterday, it was really an amazing experience. I was, and I've heard some of these speakers before, but I think just the compilation that's been put together, the scope of speakers has been outstanding. And all of us who do this work, part of doing this work is just constantly learning and listening to voices so that we can continue the work more informed. And certainly that's true for me. I think the work that we do, we really have to be listening all the time to patients' voices, to community voices, and certainly to other leaders who are doing this work around the country. So I really feel privileged to be here, but also really thankful to get to hear from so many amazing folks who've done such amazing work. So today, I'm just going to take the opportunity, thank you, to share some of our work in Illinois. We've been talking about different issues that address maternal health and maternal mortality across these 2 days. And today, I'm going to focus in on substance use disorder. We have heard about mental health, we've heard about a lot of different issues, but I think that making sure that we think about the different arenas that can lead to maternal mortality and maternal morbidity, we'd be remiss by not taking some time to think about how we can improve care for women with substance use disorder. So I'm going to give a brief overview of our LPQC. I'm then going to share about the OUD crisis, kind of where we are, what our initiative, what we've put together in Illinois, by really listening to patients, listening to hospitals, and really trying to figure out what will work. And then I'll share a little bit about what we've done or what we've accomplished so far. So briefly, you've just heard a lot about Parental Quality Collaboratives, so I don't need to tell you what they are, but this is our collaborative in Illinois. We've been going since about 2013. We're physicians, nurses, public health, patients, community stakeholders, all working together to try to improve care and outcomes for women pregnant and postpartum patients and their newborns. And we use evidence-based practices. We have had over time about 119 birthing hospitals participate, and we are really excited about the reach, about the number of hospitals that participate with us, but also the community stakeholders and the patients that really contribute, come to our meetings, sit on our advisory work groups, do focus groups with us to really make sure that we're hearing the voices we need to hear to do this work successfully. Next slide. So I'm going to focus in today, like I said, on substance use disorder. We've been talking about a lot of the causes of maternal morbidity and mortality. We just released in the end of April our new report in Illinois, and we really partner with our Department of Public Health, our maternal morbidity and mortality report, as we're doing our work in Illinois. As this was released, the leading cause of pregnancy-related deaths in Illinois are mental health conditions, including substance use disorder. And if you look at pregnancy-associated deaths, really about a quarter are from substance use disorder and overdose. And that's really is driving a huge concern in Illinois with increasing numbers of maternal deaths. And you see here why we want to focus and why our teams voted to focus on substance use disorder, specifically opiate use disorder, over these last couple of years, in addition to some of the other work we're doing, like our new birth equity initiative that that Dr. Henderson mentioned. Next slide. So opiate overdose is a leading cause of maternal death in Illinois. When we look at our overdose cases, they've been dramatically increasing. And what is really concerning is, I'm sure you've heard from headlines across the country that the COVID pandemic has made substance use disorder even a worse problem for our patients. And many women don't have access to the resources that they've had. They've been isolated, and we've seen overdose deaths go up. If you look at these 2019 overdose counts across Illinois, you see this isn't an urban problem. It's a state of Illinois problem. It's our country's problem, and overdoses happen everywhere. And certainly they happen to our pregnant and postpartum patients. I think it's really important, and we do this with all of our work. Every single meeting we have, we try to center it on patients' voices. Before we start an initiative, we do a series of focus groups specifically with patients to get input. And we have patients advisors, we have patient speakers sharing their stories. Always, it's the most powerful thing that gets our providers and nurses' attention. It really brings the passion to this work when people are thinking of specific patient stories. And that helps us to really get our head around that opiate use disorder is a life-threatening chronic medical condition, and that screening and linking pregnant patients with OUD to treatment services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of women who can parent their baby. This is really our mantra that we say over and over again to help us understand why we're screening and why we're trying to link these moms to care. Next slide. It's really important to understand that medication-assisted therapy does save lives. This is a data that came out of Massachusetts. The orange are those overdose events when patients were on pharmacotherapy, receiving medication-assisted therapy. The gray is women who are not on a pharmacotherapy. And you see about double the number of overdose deaths for patients who are not in therapy. And you also see that postpartum is a very risky time for women with OUD, making that pregnancy window an even more important opportunity to screen women with universal self-reported screening early in pregnancy and get them linked to care. Next slide. So I'm going to just briefly go through our initiative in Illinois. We started with 107 hospitals participating back in May of 2018. We've done monthly webinars and in-person meetings. And we're really trying to focus on getting women linked to MAT and recovery treatment services and identified. Next slide. These were our initiatives. We always set a series of initiatives with our hospital teams. We work with our hospital teams to figure out what data they're going to be collecting, what our measures are going to be, and this is what was established. We really focus on universal validated OUD screening, not to confuse people. This isn't urine screening. This isn't looking for women to be screened. This is really about doing a self-reported validated screening tool, similar to how we screen women for perinatal depression early in pregnancy, and then again when women come to labor and delivery, to really ask them about the experiences in their lives. Linking women to medication-assisted treatment, linking them to recovery treatment services, getting them education and counseling about OUD and NES, and then doing a clinical care checklist, making sure these moms get optimal OUD care. Next slide. We found that it was really important to teach our clinical teams key messages about what optimal OUD care is. For too long, we call it old way of thinking. Women, it was really thought that you were screening pregnant and postpartum patients so that you could identify babies at risk. More of a gotcha than how do I provide you the best care for your chronic life-threatening medical condition. We've really focused on changing thinking among our providers and our clinical team to see the mom as having a life-threatening medical condition, and that we're screening them because chronic opiate use disorder is an urgent obstetric issue. We talk over and over again that it's a life-threatening chronic disease with life-saving treatment available. There are key steps that providers must take, and that we really talk about why we're doing universal self-reported screening and linking those moms to medication-assisted treatment and recovery services early in pregnancy to reduce overdose deaths, improve pregnancy outcomes, and increase the number one who can parent. Next slide. Optimal care for all pregnant women and postpartum persons with OUD. It really comes down to these 6 elements for us that we're really pushing our clinical teams to think about this. This is not just, oh, call social work and call neonatology. You have work to do with the patient in front of you. Screen every pregnant patient for OUD with a validated screening tool, assess readiness for medication-assisted treatment, link to MAT and recovery treatment services, provide naloxone counseling and screen for Hep C, warm handoffs, and close OB follow-up. We've got to help with navigation, and then provide patient education, and then reduce stigma and promote empathy across clinical team. We really started there with many of our teams, because if we're not reducing stigma and promoting empathy, we're not going to be able to provide any of the rest of the work. And we really learned that from speaking to our patients. Next slide. I'm going to briefly go through some of our resources and tools. These were the universal screening tools that hospitals around Illinois used. I would say the 5 Ps was probably the most common screening tool they did. Next slide. These tools are all available on our website. We also learned that one thing that happened is that people screened and they didn't know what to do when someone screened positive. So we put these MNO folders together, distributed them around the state. They're in prenatal clinics, they're on labor and deliveries all across Illinois. On one side is a clinical team resources, kind of an algorithm and a checklist, teaching people how to write a Narcan prescription and a nursing workflow. And on the left side is patient education materials. We're really proud of these patient education materials. We put these together with patients with lived experience. They help to develop these materials, what they would have wanted, what they would have benefited from when they were in the hospital with their newborns with NAS. Next slides. We also did, these are that patient education materials that I said we're so proud of. So again, these are available on our website if you're interested. Next slide. We also did a lot of work on education for providers. This is really important for OB providers, for emergency room providers, for nurses. The Words Matter e-module is really an interview about a patient talking about their experience. It's been one of the most powerful things I think we've put together, and many of our teams have used that to teach stigma and reduce bias. Also, we put together modules on what optimal OUD care looks like, both for providers and nurses, and we did a whole series of posters and magnets, really drawing attention to what we need to do to save a patient's life. We also did a simulation guide to really talk about discussions and those challenging discussions and really draw out people's stigma and bias and really have conversations about what that looks like. Next slide. So briefly, just to wrap up, I'm going to share some of the data. So since 2018, we've taken care of about 2,600 pregnant and postpartum patients with OUD. About 71 women per month were entered into the data system. And then they did a random screen. Our teams did random screens for about 24,000 pregnant women to look at whether screening was accomplished. Next slide. I'm not going to go into this in any depth, but this is our systems changes. This are how our teams reported. Red, they hadn't started working on a systems change. Yellow, they were working on it. And green, they had it in place. So you can really see quality improvement in action by just looking at these slides, really getting those systems changes in place. And this is really what PQCs do. Next slide. This is the success of our universal screening. When we started, only 2% of women were screened with a validated screening tool on labor and delivery. We're now up to about 87%. We've been maintaining that in sustainability. We've had a harder time getting validated screening into prenatal care. We bump between 40 to 50% of patients being screened. This is an area that probably needs additional policy to really think about what we need to do, or if we need legislative mandates around how we get providers to really screen women in a really patient-centered way early in pregnancy and link these moms, patients to care. Next slide. We've also increased getting women linked to MAT and recovery treatment services. Next slide. We've significantly increased getting women Narcan counseling and Narcan prescriptions, but there's a long way to go. I think most pregnant and postpartum patients around the country are not getting counseled and provided Narcan when they're identified with opioid use disorder. This is an area of real interest around policy and legislation, how we can improve access to Narcan and naloxone for our patients. Next slide. We've also always, in terms of think about equity in all the work that we do, and so looking at our data by race, when we looked at Black patients versus white patients who are linked to MAT, beginning on our pregnancy, there was a huge disparity. Only 24% of Black patients were linked to MAT and 45% of white patients were. And we really were able to close that disparity gap by the end of our initiative by focusing on every patient every time deserves optimal OUD care. Next slide. We also were able to close the gap on breastfeeding for opiate-exposed newborns by really focusing on this area as well. And again, you see this gap closing across our initiative. Next slide. This is our contact information. The website has all of our resources, and that is our team's email if you'd like to reach out to it. Thank you so much.